Hello, everyone. My name is Michael Kern. I'm one of the orthopedic sports medicine surgeons here at UT Hospital. And I'm here with Christine Seaworth. We're doing a Facebook Live seminar on sports medicine injuries. Christine's one of my partners. And Christine, why don't you tell me a little bit about your background and what you do for us?
Yeah, I'm the foot and ankle specialist at our group University Orthopedic Surgeons. I also take trauma call, but I specialize in the foot and the ankle. And my extra train was in foot and ankle, and Dr. Kern's was in sports medicine. Dr. Kern, can you tell us a little bit about what sports medicine means in orthopedics?
Sure. I think, sports medicine is a very broad category, and it really kind of began as a branch of orthopedics that specialized in arthroscopy, which is kind of minimally invasive joint surgery. Nowadays, sports medicine is a term that really encompasses any injuries that you get either while playing sports or just being active. And so these days, the anatomic diversification in orthopedics and the specialization has led people to kind of branch off even to deeper areas. So sports medicine encompasses all the joints, and I do a lot of shoulders, knees, and hips, and Christine does foot and ankle.
I know that knee is a very commonly injured area. What's some of the most common knee injuries that you see?
Yeah, so I think in my mind, I like to divide things between acute traumatic injuries that happen and you know something's screwed up versus your kind of nagging problems that build over time. Probably the most common acute injuries I see for more of the young athletes are tears in the meniscus, which is a shock absorber in the knee, tears in some of the ligaments of the knee, like the ACL or the MCL, and sometimes you can even have dislocations of the kneecap. Those are probably the three most acute injuries I see.
When does somebody need to come see you after they injure their knee?
So I think part of that differentiation between an acute injury and something that's happened slowly, I think that's the key thing I would have in your mind. If you have a bad injury and a lot of swelling, particularly in the knee, that's a reason to get evaluated relatively quickly. And certainly if you can't put weight on it, that's a reason to get evaluated quickly. If you have more of a nagging problem that's been, increasing with increasing use, it's not unreasonable to try and manage it with over-the-counter medications. Ibuprofen is an orthopedic's best friend. I mean, we use it all the time. It's a great medication. And so trying that first for several weeks or changing your activity, modifying it to get a little bit more relief, even for a month or so, is not unreasonable.
When the patients come in to see you for the knee injuries, what kind of things can they expect for initial treatments, and how will you know if they need surgery?
So great question. The reality is pretty much every time you get an orthopedic evaluation, we need an x-ray. That's really to rule out a lot of problems more than it is to diagnose anything. That helps us determine if you have any fractures or any really bad joint problems like severe arthritis. And then beyond that, one of the key findings I use is do you have a fluid inside your knee joint? And it's a little bit hard to tell for a layperson whether or not your swollen knee is just generally swollen or whether there's fluid inside the knee joint, but we can kind of pick it up right away. And if I see that, I know I need to do more involved diagnostics like MRI.
If somebody ends up with an MRI, do they always need surgery, or do they sometimes get other types of treatments?
I mean, we treat a lot of things non-operatively in orthopedics, and a lot of the diagnoses that we get MRIs for are to correctly identify what's wrong and to determine whether or not you're wasting your time by trying to treat it without surgery. But certainly, collateral ligament injuries, meniscus problems, we treat a lot of those without surgery first. And then if things don't get better, you can fix it later.
I know you mentioned that one of the most common injuries are injuries to the meniscus or tears in the cartilage. Mm-hmm. When the non-operative treatment fails, what kind of surgery do people need?
Really varies depending on kind of what you're dealing with in the knee. But the meniscus, the shock absorber of the knee, if we do treat it surgically, it generally is a tear of some kind, and it requires either direct repair or it needs to be trimmed out. And that really has to do with the character of the tear. The meniscus is notorious for having relatively poor blood flow and thus poor healing potential in the knee. So if you do have a tear in it, it frequently can be in an area that won't heal. So.
And I know as we get back to school and it becomes football season, everybody's starting their sports. Are there any type of injuries that be more common in the knee in the fall and when sports start up?
ACL injuries are much more common. Those are that's Probably most people have heard of that by now, is that's the stabilizing ligament of the knee. Very easy to tear it in a cutting or pivoting sport, even without contact. And when you add contact into the mix like you do with football or lacrosse, it can really increase the risk. If you do, if you're a young athlete and you feel a pop in your knee and you're swollen, it's something you want to get checked out. So,
what kind of recovery would you expect from an ACL reconstruction of the knee?
So ACL, I like to tell all my patients, when you tear your ACL and you get it fixed, and pretty much all ACL tears need surgery to get it fixed. It's kind of like a college level course. You start the surgery is the easiest part. You get through the first couple days, and after that, it is months of work. And the early phase, we're working on range of motion for the first 2 months. And after that, it's strengthening, because the real key with ACL recovery is you have to reduce the risk of a repeat ACL tear. And the biggest risk that you can have returning to play is having a weak leg.
All right, are there any other injuries that are very common in high school and college athletes that oftentimes must need surgery to get better?
I think, the other one that I like to mention is kneecap dislocations. Most of those I can usually treat without surgery early on. Part of the reason for getting that MRI is to make sure that you can do it safely. But if you do dislocate more than once, it's something that ends up needing to be fixed.
And when you're fixing that, what are you trying to prevent besides repeat dislocations?
Well, a kneecap that continues to dislocate over and over again, and this is close to my heart. My brother had a kneecap dislocation when he was really young, and back when he did it, they treated it without surgery until you had dislocated 2-3 times. And every time you come out, you have the chance of knocking off more cartilage, and you increase your rate of continuing to come out. And I think over time, you can develop arthritic change in the knee, which as a young player is really difficult to deal with. So, why don't you tell us a little bit about some of the foot and ankle injuries that we see, Christine? What are some of the most common injuries you see?
One of the most common injuries is an ankle sprain, and it's one of the most common reasons for people to visit their primary care doctors and also the emergency room. Some estimates think there's 25 to 30,000 people a day in the United States that sprain their ankle, so it can be very, very common. Walking on uneven ground, stepping in a hole, sporting activities where you're cutting and turning, or even people that have more of a natural high arch to their foot put people at higher risk for this injury.
And so when should somebody who sprains their ankle, because I think a lot of people sprain their ankle don't see anybody, when should they see somebody?
So very similar to the knee, if you have a lot of swelling and a lot of bruising, it's important to get an x-ray to rule out fracture, because sometimes we think it's just a sprain, but it can be a fracture in the bone in the ankle or even in the foot. If it's just sore and feels much better within 2 or 3 days, you probably don't need to see a doctor.
Mm-hmm. And if they have trouble weight bearing on it, is it okay to wait a couple days, or?
I think if you can't weight bear at all, it'd be something that you'd want to get seen for very quickly. Our clinic does have an urgent care walk-in clinic here at UT Medical Center in our office, and it's available Monday through Thursday from 8 to 4 a.m. and on Friday from 8 a.m. to 11 a.m. So we do try to make that care very convenient for you.
Mm-hmm. Now, sometimes people talk about high ankle sprains. What is that?
So when you think about your basic ankle sprain, it's not a high ankle sprain. It's the ligaments below the ankle. When they say high ankle sprain, they mean the ligaments that are right above it. You'll hear very commonly that football players get it, and those ligaments also stabilize the ankle but can take much longer to heal. There have been some pretty famous college football players that have had one and required surgery, but instead of your general ankle sprain, which may feel better in 4 to 6 weeks, this one can take longer, like 2 to 3 months, and sometimes require surgery.
Mm-hmm. When do your routine ankle sprains require surgery?
So for routine ankle sprains, usually we start care non-operatively first. If you have a lot of bruising and swelling, you can't weight bear, we'll put you in a boot and crutches. If you're able to walk but you're limping and it's sore, we'll just give you a basic ankle brace as laces and straps to give you some stabilization, support, and pain control. And we really always start with physical therapy, because that's very important to getting your motion back, your strength back, and preventing repeat injuries. People that just have your basic ankle sprain that need surgery, that can happen if you tear some cartilage within the ankle. You keep having ankle sprains over and over, and it becomes a chronic issue. Or if you were to fracture one of the bones around the ankle, sometimes you'll need a surgery for that.
Mm-hmm. And what happens if, let's say, somebody has a bad ankle sprain? Are they condemned to wear a brace the rest of your life for sports, or what's the
No, it's a
thoughts
very
there?
very common question, and people are very worried about wearing the brace for too long or not long enough. And that's why physical therapy is very important to help guide you. People that have a lot of ankle sprains may end up wearing their ankle braces when they're active to prevent repeat injury, especially if they're going to be on uneven ground or cutting sports. But generally, we like to see people be able to participate in their day-to-day life without bracing. If you were to require bracing in your day-to-day life, to keep your ankle from giving out, then a lot of times I'll recommend surgery to tighten the ligaments up and prevent repeat injuries, cartilage injuries, and even arthritis long term.
Now, you do ankle scopes too, right?
I do, yes.
And when do one of those indicate, or when do you do those?
So they can be indicated for a lot of different reasons. One of the things that can commonly happen with an ankle sprain that's very severe or recurrent ankle sprains is that you can chip or tear the cartilage within inside the ankle joint, which can be very painful. That's something that I treat through a scope where I go in and clean out the torn cartilage. But I also do an ankle scope for people that have had ankle pain for some time and are developing early arthritis and develop bone spurs in the front of the ankle that pinch when they flex and bend their ankle, and cleaning that out can help decrease the pain.
Got it. That's interesting.
What about shoulders? Are shoulders, you see something very frequently?
Yes, so I see a lot of shoulder problems both in contact athletes and in repetitive overhead athletes. Yeah.
So what kind of injuries are more common in contact versus repetitive?
So I think the big thing I worry about with contact is dislocations. The shoulder is the most mobile joint in the body, and as a result, it's more likely to dislocate than almost any joint in the body. And subsequently, when you do have a dislocation, you can injure things when you dislocate. And so pretty much anytime somebody has a dislocation, we get an MRI to make sure that they haven't done any severe damage to their shoulder. But primarily the main problem when you dislocate is coming out over and over again, continue to dislocate. And probably most people that have played sports know somebody like this that was able to dislocate their shoulder and had to pop it back in. And sometimes people get so bad with this that it happens even when they're sleeping. Repeatedly coming out can be really bad for your shoulder. So that's something that we generally need to fix.
I know people can dislocate their shoulder at any age. Do you see different types of injuries, whether they're young or old, when they dislocate their shoulder?
Yes, great question. So that when you are a young person, you dislocate, traditionally you tear something called a labrum, which is kind of a rubber gasket around the socket of the ball and the socket shoulder. That really is more of an issue with persistent instability, like I was mentioning. But as soon as you kind of get beyond 40 years old, if you do dislocate, like let's say you do it in a fall or a bicycle accident or something along those lines, now we're much more concerned about tears in a structure called the rotator cuff. And the rotator cuff is a small series of muscles that wrap the ball and socket joint, and they're really important for controlling your arm when your arm's out in space.
And is the treatment the same after somebody initially dislocates their shoulder regardless of age, or does it depend on their age?
It depends on the injury itself. If I have a young athlete who has a pretty routine shoulder dislocation, they almost by definition tear their labrum, we'll rehab that patient. And likewise, let's say I have an older patient that has a partial tear of the rotator cuff, but not totally torn, I'll rehab that patient as well. But once the soft tissue injuries become more severe, you start getting worried about persistent instability or dysfunction, and then intervening earlier makes more sense before it gets too bad.
And how do you intervene on those? How do you fix a rotator cuff tear?
So pretty much everything these days is done through the scope. The rotator cuff tears are really repaired through a series of anchors. We kind of tie the tendon right back down to the bone, and then we just got to wait for biology to work its magic. Labral tears, it's very similar. We tie the labrum and the capsule down to the bone, and the one exception to all this is, let's say you're one of those people that has dislocated 25, 30 times. Sometimes you can wear some of the bone down in the shoulder, in which case I do have to do something with an open procedure rather than just a scope.
And if you have a dislocation and you don't take care of it in your shoulder, what kind of long-term bad problems can happen?
Primarily arthritis, and that can happen relatively quickly if you got really bad instability, and just kind of like with the knee, it's one thing if you get arthritis when you're 60 years old, it's easier for us to manage. If you get arthritis in your 30s, 40s, it's much more difficult.
And what kind of treatments do you do for shoulder arthritis?
Shoulder arthritis, just like knee or hip arthritis or ankle arthritis, the end stage surgical treatment, the only one that really works is a replacement. And we have replacements for the shoulder and they work really well. But just like all the replacements we put in, they all have a lifespan on them. And so if you do it in somebody that's too young, they'll outlive their replacement. And now they're looking at a redo of the replacement. And every time you redo one, the potential problems kind of get more and more magnified.
I know another sports injury that happens occasionally, can sometimes people dislocate their collarbone. Can you tell me about that?
Yeah, so that is called a separated shoulder, and I see a lot of those as well. Those are a little bit different. It's not common I need to fix them. Most people can rehab those and get better, and even if they have a fair amount of deformity or a little bit of a bump at the AC joint, it doesn't tend to cause a lot of significant dysfunction unless it's really out of place. So we typically just get an x-ray for that, and then most of them I rehab.
And I know we were talking a little bit about arthritis of the shoulder. How does that affected when you do steroid injections with the current COVID pandemic and vaccinations?
Yeah, so right now we don't have a lot of information on this because everything's still so new, but all steroid injections do have an anti-inflammatory effect and basically they suppress the kind of localized immune response. So when we're vaccinating people, we're trying to generate an immune response. So we try and avoid the vaccination dosages by about 2 weeks anytime we're doing a cortisone injection. So what does this mean? It means that if you're somebody with arthritis and you need an injection, don't come in 2 days before your vaccine dose because we're going to want to hold off.
You always want to leave 2 weeks ahead and behind the actual vaccine with steroid injections.
Now, Christine, one of the other injuries I hear all about is Achilles ruptures, and I see a fair amount of those. You manage those as well, right?
Yes, very common, especially much more common in men, about 5 times more common in men than in women. Tends to happen in about age 30 to 40, but I've seen people in their late teens all the way up into their 80s and 90s that have this injury. Sometimes we treat this without surgery, but most of the time this is something we want to treat with surgery because people overall have better long-term outcomes, better strength, and better balance. One of the most common complaints I see when people come in that don't realize they've ruptured their Achilles is that their balance is off and they can't walk.
Mm-hmm. Now, you see tendonitis in this area too, right?
I do. So much more common to have tendonitis in the Achilles tendon where it attaches to your heel bone. The Achilles is a major tendon in your body that attaches your calf that helps flex your foot down to the heel bone in the back. And so especially when you have a tight calf muscle or lots of strain on your Achilles, you'll get tendonitis where it attaches there, and you may even develop a heel spur. Usually we can treat this without surgery in the beginning. We work on changing your shoe wear, stretching, physical therapy, and sometimes you even have to wear a boot to let everything and all the inflammation calm down.
Now, when you fix an Achilles, either for a chronic or an acute problem, how are you doing it?
Yeah, so it's a different surgery based on what your actual problem is. If you actually rupture your Achilles tendon, that happens more oftenly in the mid-substance or the middle part, about 6 centimeters above or 2.5 inches above where it attaches to the heel bone. And what happens there is that you think about a rubber band, you pull it tight and you cut it in the middle, it snaps back. So with repairing the tendon, what we're doing is I'm pulling the 2 edges of the tendon together and suturing it together with non-dissolvable stitches so it can heal and scar in, at the correct tension and with good strength. With chronic tendonitis, that's different, and it's a different condition, and it's a general wear and tear of your tendon. And so what I'm doing is I make a cut down the back of the heel, split the tendon, pull it off the bone, take out all the spurs, and then I cut out all the worn out degenerative tendon because that can be a big source of pain. And then I repair it back down to the bone with anchor. Is very similar to having your rotator cuff repaired in your shoulder.
Is there anything people can do to prevent these types of problems?
So staying very active, especially making sure you're involved in a good stretching, warm up and cool up program, making sure that you don't avoid repetitive activities, making sure you cross train can help prevent these.
Okay, great. Well, I think that's all for my
We have
questions.
a couple of questions from the audience.
Okay.
Sure.
Thank you all. So the first one is, I'll just throw it out to both of you to speak to, but what about back injuries? Do you all treat that or see that?
Usually we recommend that you start with sore low back pain with your primary care provider. A lot of times they'll start with x-rays and physical therapy as a baseline of treatment. We don't have any back specialists in our practice. I don't know if you have any other comments regarding injuries in sports for the back.
I mean, I see, well, so most of the time, if you have an acute back injury during sports, it's very dangerous. So that's something we treat very, very aggressively as far as immediate imaging and care. But that's the rarity. I think most people deal with more chronic back problems. And I tell people that while we don't have any back specialists, I do occasionally manage it solely because it ends up overlapping with some of the other problems I see. But typically, if you end up needing any sort of procedural work, things like injections or even surgery, we end up referring you out. One of the things I always recommend to all my patients, particularly those with back problems, is core strengthening. I think these days, especially people that work 9 to 5 and they're sitting all day, it's really easy to fall behind with core strength, and that goes for abdominal strength and lower lumbar strength. And so working those muscle groups out, even though it's counterintuitive, is much, much, much better than sitting down.
And is that something you usually send people to physical therapy for, or can they find those exercises online?
Occasionally, you can send people to therapy, and therapists are really good at it. Some of the chiropractors around town can manage it pretty well too. No joke, I had one spine surgeon I worked with that used to prescribe Pilates. So anywhere you can get it is great. Yoga is good too.
Great. And then another question for you both. What are your thoughts about arm injuries in youth baseball players? Is there a rise in this? And I guess that might be that repetitive.
I'm going to defer to Dr. Kern on this because this is...
Yeah, there's definitely a rise in it. We see a lot of elbow and shoulder problems with repetitive overhead athletes. And I'll tell you just anecdotally that we see problems in elbows in 15 and 16-year-olds that we used to not see until the patients were 25 years old now. And the reason for that is all year-round play, and it's gotten a little bit better now that people are a little bit more vigilant about pitch counts and days off and things like that. But one of the things I tell all my young athletes is the best single thing you can do if you're a single sport athlete is to take a solid 3-month block in the year and spend it cross training and not playing your sport. And the reason for that is your average tendon injury, bony injury, you name it, any musculoskeletal problem, most of them will heal completely in 6 to 12 weeks. So that means if you're not giving your body that time period to recover completely, those kind of small insults can build up over time and then really become a problem. And that's why we see, you see pitchers with Tommy John problems at age, 14 and stuff like that. Yeah.
Wow.
What is a Tommy John problem?
Yeah, so, when you do a biomechanics study of somebody pitching high speed, their release point is equivalent to hanging bowling balls off the back of their arm. That's the amount of force that's going through the elbow right here. And that's all going through at one phase of your pitching routine. It's all going through the ulnar collateral ligament, which is the ligament on the inside of the arm, the Tommy John ligament. When that blows out, you really don't have any choices. I mean, sometimes if it blows out acutely, it does have a healing potential. But most of the time when it blows out, we see it over time, just repeated insults. And those end up needing to be repaired or reconstructed surgically.
And what kind of long-term problems can the young athletes get if they develop this problem, even if they do have it surgically fixed?
Well, one of the myths out there is that you get faster if you have Tommy John surgery. I think that myth arose because, well, I'm not really entirely sure, but I believe it was because Tommy John was throwing terribly, and then when he came back after he had it fixed, he was throwing a little bit faster. But he certainly wasn't faster. Nobody's faster than their pre-injury speed velocities. So the real issue is it's a long recovery. It can potentially knock you out for 2 seasons if it happens at the wrong time.
Wow.
And we see improvements in velocity and mechanics up to 18 months out from the surgery.
Wow. Great. Thank you. And then a question for you both, looks slightly different, but I think it's relevant, but just this current COVID surge, what are you seeing with your patients? And, would you encourage people to still come see you despite what we're hearing about the new rise in COVID cases?
Yeah, we encourage everybody to become vaccinated. That's one of the best things that we can do to help ourselves, our families, and just our community to prevent spread and to prevent severe cases. Also helps keep the hospitals from becoming overloaded with patients that are sick with COVID. So if you were to have a sports injury and need a surgery, you can get that done. Or if you're in a car accident, you can still be taken care of. Patients are starting to have to cancel appointments because they are coming down with COVID. And so they're not getting the appropriate care before, during, and after their injury or surgery that they need, because we're having to do it over the phone or in the parking lot or delay it, and that's just not ideal for anybody to get their best outcome possible. We are having to limit surgeries at the hospital right now to outpatient only. Anybody that's an inpatient surgery and it's an elective procedure cannot have their surgery done because there's not enough beds in the hospital to stay overnight.
Add anything to that?
No, just that, I mean, it's a problem when the hospital starts limiting surgeries, because it's a really valuable thing for the hospital in terms of income. So, and my hope is that we won't get to the point where we're close to shutting down all surgeries, but we were really close to that point a second time last winter.
Last winter, yeah.
And so we'll see.
Yeah. Well, thank you both for your time. Maybe for people who are just now joining in, if you can share again how people can contact you if they, have a sports injury or need some assistance.
My name is Dr. Christine Seaworth, and this is Dr. Michael Kern. We work for University Orthopedic Surgeons, affiliated here with UT Medical Center. Our office phone number is 865-546-2663. And we also have a website online at UOS Ortho, which is UOSORTHO.com, where you can find all our bios and websites and a way to schedule an appointment.
Great.
And just to add to that, we just had a question come through. They're just joining in, but do you have an urgent care? So maybe
We do have an urgent care. We have it Monday through Thursdays, 8 to 4 at our UT location. We have a map of that on our website, and also on Fridays from 8 a.m. to 11 a.m. as well.
All right. Great.